So our today's topic, preventive dentistry. This presentation will have two parts. First part, preventive dentistry, and second part, I will give you information about the Pitt and Fisher's sealants. I would like to begin our lecture from a very important phrase. An ounce of prevention is worth a pound of dental cure. What does it mean? It means that prevention plays a major role in dentistry at all. And contents of our today's lecture. Of course, introduction, history of preventive dentistry, objectives, preventive dentistry, levels of prevention, prevention of dental caries, principles of prevention periodontal diseases, principles of prevention malocclusion, principles of prevention oral cancer, role of public health dentist. Shortly, we will tell about future challenges and, of course, conclusion. Let's begin from introduction. First of all, I would like to tell with you about meaning word prevention. What does it mean, prevention? If we ask Cambridge Dictionary about prevention, we will find it. We will find that prevention, it is the act of stopping something from happening or of stopping someone from doing something. But it is not medical notion, it is common notion of word prevention. A word prevention is derived from the word preventio, from Latin. It means foretelling, equal to act beforehand. So prevention is the same to keep from happening and making possible by prior action. Prevention is defined as actions taken prior to the onset of disease, which removes the possibility that the disease will ever occur. It is medical notion of prevention. Next chapter, history of prevention dentistry. 19th century. Majority of prevention satisfied by home care remedies. 20th century. Etiologic factors of most orodontal disease were identified emergence of prevention. In the first three decades, great emphasis was placed on oral hygiene. In the fourth and fifth decade, anti-caries effect of fluorides was established, and water fluoridation and topical fluoridation started. In the 6th and 7th decade, fluoride toothpastes, mouthwashes, rinses, gels, and varnishes became popular, and pit and fish sealants were also used widely. Next chapter, objectives. Objectives of prevention are next. First of all, to avert initiation of disease process. Then, to intercept their progress. Next objective, to control their spread. To limit their complications and after effects. To provide rehabilitation. Now let's talk about scope of preventive dentistry. Factors predisposing of disease, for example, dental plaque and other deposits. Factors encouraging the advancement of disease. Example criteria: host resistance and TFO. Next point, complication of disease and deformity. For example, loosening, drifting of teeth. Factors interfering with rehabilitation, like defective restorative dentistry. And factors causing recurrence of disease. For example, poor oral hygiene, lack of patient motivation, etc. But successful prevention is possible only in the next conditions. Parts of successful prevention are next: knowledge of causation, dynamics of transmission, identification of risk factors, availability of prophylactic or early detection, treatment measures, organization for applying these measures, and continuous evaluation of procedures applied. And please, colleagues, note that only complex of all these factors can provide successful prevention of dental diseases. Next chapter of this part of our lecture, levels of prevention. Prevention has next levels. First of all, primordial prevention. Next level, primary prevention. Then, secondary prevention. And, yes, you're right, tertiary prevention. And what modes of intervention or preventive services are known? First of all, health promotion. Then specific protection, early diagnosis and treatment, disability limitation, and at the end, rehabilitation. Let's talk more detail about levels of prevention. Primordial prevention. Prevention of emergence of or development of risk factors in countries or population groups in which they have not yet appeared, called primordial prevention. For example, efforts directed towards discouraging children from adopting harmful lifestyles, etc. Here, the main intervention is by individual and mass education. Primary prevention, next level of prevention, defined as action taken prior to onset of disease, which removes the possibility that a disease will ever occur. Phase of intervention, pre-pathogenic phase. It is phase when pathology is not developed yet. Specific causal factors or risk factors are already, but specific causal factors or risk factors are already present. Modes of intervention for primary prevention. The health promotion and specific protection. The World Health Organization approaches for primary prevention of chronic diseases are next. Population or mass strategy and high risk strategy. Let's talk about population or mass strategy. Population or mass strategy directed at the whole population, irrespective of individual risk levels. Aims at socioeconomic, behavioral, and lifestyle changes. For example, a small reduction in the average blood pressure of a population would produce a large reduction in cardiovascular disease. Health education to improve oral hygiene practices. High risk strategy aims to bring preventive care to individuals at special risk. Requires detection of individual at high risk by the optimum use of clinical methods. For example, topical fluoride application for those with high risk. Next level of prevention, secondary prevention. We talk about primordial prevention, primary prevention, next level, secondary prevention. Secondary prevention defined as action which halt the progress of disease in its incipient stage and prevent complications. Phase of intervention, pathogenesis phase. In other words, phase when dental diseases are present. Health programs initiated by government are at this level. And now let's talk about modes of intervention for secondary prevention. The early diagnosis and prompt treatment. And last level of prevention, tertiary prevention. Tertiary prevention defined as all measures available to reduce or limit impairments and disabilities, minimize suffering caused by existing departures from good health to promote patients' adjustment to irremediable conditions. Phase of intervention, late pathogenesis phase. And modes of intervention for tertiary prevention, the disability limitation and rehabilitation. What about health promotion? Health promotion defined as a process of enabling people to increase control over and to improve health. It involves organizational, political, social, and economic interventions designed to facilitate environment and behavioral adaptations that will improve or protect health. And it includes few levels. First of all, health education, then environmental modification, nutritional intervention, and lifestyle and behavioral changes. Let's talk about health education. What is this health education? It is one of most cost-effective intervention. Adequate information about diseases and encouraging people to take necessary precaution in time. Target group for educational efforts include general public, patients, high-risk groups, community leaders, decision makers, health providers. The next one, environmental modification. The history of medicine. Many infectious diseases have been successfully controlled in Western countries through this intervention. Not clinically, don't involve the physician. Example of it: provision of safe drinking water, improvement of housing, control of insects and rodents, community water fluoridation. Then, nutritional intervention. Examples of nutritional interventions: food distribution and nutrition improvement of vulnerable groups, child feeding programs, dietary counseling. lifestyle and behavioral changes. Example of it: motivating people to avoid smoking, pen chewing, and drinking alcohol. And specific protection. It means to avoid disease altogether is the ideal, but this is possible only in limited number of cases. What parts of specific protection? First of all, it is immunization, pit and fissure sealants, water fluoridation, chemoprophylaxis. And only complex of these actions can give us effective specific protection of oral diseases. Let's talk about diagnosis and prompt treatment now. In order to prevent overt disease or displacement, the criteria of diagnosis is possible be based on early biochemical, morphological, and functional changes that precede the occurrence of manifest signs and symptoms. The earlier a disease is diagnosed, the better it is from the point of view of prognosis and preventing the occurrence of further cases or any long-term disability. Examples of it are oral cancer screening, hypertension screening, or AIDS prophylaxis. Then, disability limitation. I would like to show you a scheme of concept of disability. Disease includes impairment. What does it mean? It means that any loss or abnormality of psychological, physiological, or anatomical structures or function. Next, disability. Any restriction or lack of ability to perform an activity in the manner or within the range considered normal for a human being. And handicap. Disadvantage for a given individual resulting from an impairment or a disability that limits or prevents the fulfillment of a role that is normal for that individual. And rehabilitation. Medical rehabilitation includes restoration of function, like prosthesis, includes dental prosthesis, speech therapy, etc. Vocational rehabilitation, restoration of capacity to earn a livelihood. Social rehabilitation, restoration of family and social relationships. And psychological rehabilitation, restoration of personal dignity and confidence. The shown table About prevention concepts in the health disease continuum. As can you see, they are shown three levels of prevention: primary, secondary, and tertiary. And prevention concepts. Priorities of prevention. In primary level of prevention will be prevention of disease initiation. In secondary level of prevention, it will be prevention of disease progression and recurrence. And priorities of prevention in tertiary level of prevention will be prevention of loss of function. Next prevention concept is taxonomy of prevention. And this concept in primary level of prevention is prepathosis. In secondary, intervention, but in tertiary, replacement. Preventive series concept. In primary level of prevention, it will be health promotion and specific protection. In secondary level of prevention, the services include early diagnosis and prompt treatment. And in tertiary level of prevention, preventive services will include disability limitation and rehabilitation. And please notice that all prevention concepts called health disease continuum, and primary and half of secondary, primary level of prevention calls prepathogenesis, before disease development, but secondary and tertiary levels of prevention are in pathogenesis stage. In other words, after developing of disease. Next chapter, prevention of dental caries, scheme of prevention of caries. Not different actions, but common scheme. As can we see, the same principle of table, three levels of prevention: primary, secondary, and tertiary. And different preventive services. First, preventive service, group of services provided by the individual. And in primary level, it can be health promotion, like diet planning, demand for preventive services, periodic visit to the dental office, and specific protection, appropriate use of fluoride, ingestion of sufficient fluoridated water, appropriate use of fluoride prescriptions, use of fluoride dentifrice, oral hygiene practices. The secondary level of prevention It will be early diagnosis and prompt treatment of oral diseases or dental diseases. And services provided by the individual will be self-examination and referral, use of dental services. But in tertiary level of prevention, preventive services will include disability limitation, use of dental services, and rehabilitation, the same services, use of dental services. Another level, services provided by the community, not individual, but by the community. And in a primary level of prevention, health promotion, it is dental health education programs, promotion of research efforts, lobby efforts, and specific protection, community or school water fluoridation, school fluoride mouth rinse program, school fluoride tablet program, and school sealant program. On secondary level of prevention, it will be periodic screening and referral, provision of dental services. And in a tertiary level of prevention and disability limitation, it will be provision of dental services like rehabilitation part 2. And services provided by the dental professional. Primary level of prevention, health promotion, the patient education, plaque control program, diet counseling, recall reinforcement, dental caries activity tests, and specific protection by services provided by the dental professional. Topic application of fluoride supplement rinse prescription, pit and fissure sealants. Secondary level of prevention with services provided by the dental professional. It will be different actions for early diagnosis and prompt treatment. It includes complete exam, prompt treatment of incipient lesions, preventing resin restorations, simple restorative dentistry, pulp capping, and tertiary level of prevention with services provided by the dental professional. There will be actions aimed to the disability limitation, complex restorative dentistry, pulpotomy, root canal therapy, or extraction. And a rehabilitation part, removable and fixed prosthodontics, minor tooth movement, or implants. Then, scheme of periodontal diseases prevention. This scheme looks like previously one. And for primary level of prevention, by service with services provided by the individual. For health promotion, There will be periodic visits to dental office, demand for preventive services, and specific protection, oral hygiene practices. On secondary level of prevention, the early diagnosis and prompt treatment will include self-examination and referral, use of dental services, and tertiary prevention, level of prevention, includes use of dental services for disability limitation and rehabilitation. Next main part, services provided by the community for prevention periodontal diseases. In primary level of prevention for health promotion, we can do health educational programs, promotion of research efforts, provision of oral hygiene aids, lobby efforts, and specific protection for services provided by the community, supervised school brushing programs. In secondary level of prevention, for early diagnosis and prompt treatment by the community, we can do periodic screening and referral, provision of dental services, and tertiary level of prevention in services provided by the community, their provision of dental services for disability limitation and rehabilitation both, and services provided by the dental professional. I am sorry. What can we do to prevent malocclusion? The same scheme of prevention of malocclusion like previously. Individual prevention in primary level of prevention, periodic visits to dentist like health promotion and use of protective devices and habit control like specific protection. In secondary level of prevention, for early diagnosis and prompt treatment in individual level, we can use of dental professional services and the same actions we can provide in the tertiary level of prevention for disability limitation and rehabilitation. In common level, for health promotion in primary prevention level, we can propose DHA program, promotion of protective. Do you understand? DHA, it means a dental health education program. Promotion of protective covering and protective guards. And for specific protection, mouth guard programs, safety measures for play. In secondary level of prevention, we need to the early diagnostic and prompt treatment, and in common level it will be provision of dental services. The same actions in tertiary level of prevention. And dentist prophylaxis, which will be patient education and caries control, periodontitis control, space maintainers, prenatal care, parent counseling. The primary prevention. Secondary prevention from dentist, minor orthodontics, and tertiary prevention, major orthodontic surgery, and maxillofacial and prosthodontic and plastic surgery. And prevention of oral cancer. The same principle of table. An individual level, like primary prevention, it will be periodic visits to dentist and avoidance of known irritants. Secondary prevention in individual level, self-examination and referral. And tertiary prevention for disability limitation and rehabilitation too. There will be use of dental professional services. In a community level, for primary prevention, like health promotion and specific protection, we need to provide dental health educational program, promotion of research efforts. Secondary prevention, in common level, periodic screening and referral, and like tertiary prevention, in common level, there will be provision of dental services. And dental prophylaxis by dentist. There will be patient education and motivation, like health promotion, and like specific protection will be removal of known irritants in the oral cavity. Like secondary prevention, complete examination. In the case of prevention of oral cancer, secondary prevention will be in cases when a patient has facultative pre-cancer status, like leukoplakia and others. What doctor can do for these patients? Complete examination, biopsy, oral cytology, complete excision. And in cases when we will need tertiary prevention, when cancer was appeared and treated, to disability limitation we can use chemotherapy, radiation therapy, and surgery. And in rehabilitation stage, maxillofacial and prostoplastic surgeries. Now, in short, about the role of public health dentist. Role of public health dentist in prevention of dental diseases. Firstly, identify and define the problem and risk groups. Advocate and involve appropriate preventive measures. Evaluate the applied program. What future challenges? Future challenges. The socio-economic disparities in providing healthcare, reoccurrence of same communicable diseases which are successfully controlled past, prevention of chronic non-communicable diseases, and population control. And conclusion of this part of our today's lecture. Nowadays, more efforts on the part of individual and government is needed to bring the developments in preventive dentistry within the reach of common man. And please, doctors, notice that our objective should be the perpetual preservation of what remaining rather than meticulous restoration of what is missing. And now, second part of our today's lecture, pit and fissure sealants. And of course, firstly, let's talk about definition. What does it mean? Pit and fissure. Pits are pinpoint depressions at the junction of developmental grooves or at terminals of those grooves. Fissure. It is defined as deep clefts between adjoining cusps. What does it mean, pit and fissure sealants? Definition. Sealant has been described as a material placed into the pit and fissures of caries susceptible teeth that micromechanically bonds to the tooth, preventing access by carcinogenic bacteria to their source of nutrients. This definition was given by Simonsen in 1978. Application and mechanical bonding of a resin material to an acid-etched enamel surface, thereby sealing existing pits and fissures from the oral environment, according to Pinkham. What types of fissures we know? According to Nagano, 1960, there are 4 types of fissures based on the alphabetical description of shape they. Of shape they are V type, wide at top and gradually narrowing towards the bottom. U type, almost the same width from top to bottom. I type and extremely narrow slit. IK type, extremely narrow slit with a larger space at bottom. Inverted Y type. The shallow wide V and U-shaped fissures tend to be self-cleaning and somewhat caries resistant. First 2 types of fissures. But deep, narrow, I-shaped fissures are quite consistent and resemble a bottleneck. I and K fissures are more caries susceptible. And classification of materials used as fissure sealants. First group of materials for this purpose was developed from 1904 till 1950, and it called early sealants or early material. It was silver nitrate, zinc phosphate and amalgam, prophylactic odontotomy, and black copper cement. And newer from 1996 till present days. Newer materials: cyanoacrylates, urethane resins, bisgma resins, glass ionomer cements, and resin-modified glass ionomer cement. Next classification, according to generations. First generation sealants, polymerized with ultraviolet light at a wavelength of 365 nanometers. There was cyanoacrylate-based materials, classified as accepted by American Dental Association in 1976. For example, Alpha Seal or Nova Seal. But that materials was failed due to excessive absorbed ultraviolet light, prevented complete polymerization of sealant at its depth, inconsistency of a wavelength from the ultraviolet light source, and the potential for retinal damage with long-term exposure to ultraviolet light. And second generation sealants, better formulations, maybe self-cured or chemically cured, mostly unfilled resin, better retention clinically than first generation sealants. For example, Concise, White Sealant System, and Dalton. And third generation of sealants, light cured by visible blue light at a wavelength of 430 nanometer and 490 nanometers. Maybe unfilled or filled. Initiator, camphoroquinone, for example, light cured Dalton, light cured white sealant, and Prisma Shield. Advantages of third generation sealants: no mixing of resin needed, eliminates incorporation of air bulbs, and viscosity remains constant. Another classification of sealants based on filler content: unfilled or free of fillers. Their features: flow is better, retention is more, and abrade rapidly. For example, Concise White. And filled. Their features: a need for occlusal adjustment, but more resistant to water. For example, Prisma Shield or Fluoro Shield from Dentsply company. And next classification based on translucency. According to translucency, all sealers are divided into clear, aesthetic, but difficult to detect at auricular examination, better flow than tinted or opaque, and more easily appreciated by the patient, and tinted or opaque, can be easily identified, for example, Dalton. And last scream of dentistry, colored sealants. They're easy to see during placement, easy to see during recall checkup. For example, Clean Pro Pink. The sealer really has light pink color. And classification based on curing. According to this science, sealants are divided into auto-polymerizing. Features of this group are better retention, near 88%, and set by exothermic reaction. And light cure. Level of retention is less, near 75%. And let's summarize information about sealants. What requirements for sealants we have? First of all, a viscosity allowing penetration into deep and narrow fissures, even in the maxillary teeth. Adequate working time, but rapid cure. Good and prolonged adhesion. Low sorption and solubility. Minimum irritation to tissues. Resistance to wear. And karyostatic action. As can you understand, doctors? It is requirements for ideal pit and fissure sealant. And you understand that it is impossible to have all these features in one bottle. It is like wishes of girl about ideal man, ideal boy. It's unreal. Next, classification based on caries risk. Risk according to Simonin, 1984. Group 1. It is classification of patients. Group 1, caries-free patients judged to be with no risk of decay. Group number 2, patients judged to be at moderate risk of decay. Group number 2. And group number 3, patients with remnant caries at a high risk of decay. Group number 3. Next, classification of patients for pit and fissure sealants based on clinical judgment. Age of the patient, state of oral hygiene, familial and individual history of dental caries, tooth type and morphology, dietary habits, fluoride, environment and history. And they are shown indications and contraindications by RIPA 1983. the three main groups of teeth with caries, questionable or sound. And with this table we can take decision according to clinical consideration what we need to do. Do seal or don't seal. In case of caries, we need to seal if pits and fissures are separated by transverse ridge. Sounds, pit or fissure may be sealed. And don't seal when caries, pits or fissures. In this case, we need to fill caries cavities. In case of questionable surface diagnosis and status of proximal surfaces, we need to seal if sound and don't seal if caries. And in case of general caries activity of clinical consideration, we need to do seal. In case of many occlusal lesions, few proximal lesions, and don't seal in case of many proximal lesions. And sound surface diagnosis and according to occlusal morphology, we can do seal. We need to do seal in case of deep, narrow pit and fissures, and don't seal in case of broad, well coalcid pit and fissures.